Hi, good morning. I am Dr. Kim Reiss. I am an assistant professor of medical oncology at the Abramson Cancer Center at the University of Pennsylvania. And today I'm going to be talking about therapeutic advances in BRCA-related pancreatic cancer. These are my disclosures. So today we're going to talk about pancreatic cancer as a whole, some of the diagnostics, a little bit of a primer on where we are in the general treatment of this disease. And then we'll move on to talk about the relevance of BRCA mutations, the options and the current science for inoperable patients and also for operable patients. We'll spend a little bit of time on screening studies, although I know other speakers in the conference are going to spend more time on that topic. And then we'll talk about beyond BRCA, in other words, other mutations and other alterations that might have therapy related to them. So I'm going to start with a brief clinical story, somebody that we take care of at the University of Pennsylvania. He was diagnosed in 2012 with operable pancreatic cancer. He underwent surgery in June of 2012. Of 2012. And he then received what was the standard of care at that time, which was 6 months of gemcitabine chemotherapy. He recurred, unfortunately, right at the tail end of that treatment and started with FOLFIRINOX, which is still one of our standard regimens of treatment for pancreatic cancer. It's an effective regimen for metastatic disease. And he was on that for, as you can see, quite a long time without any evidence of progressive disease. So he was continued on chemo. During that period of time, he was tested genetically and was found to have a BRCA2 mutation. And he was doing very well on chemo. His tumor was nice and controlled, but the side effects over, as you can see, almost a 1.5 year period were certainly accumulating. He was tired, he had mouth sores, his blood counts weren't great, and he had worsening nerve damage and diarrhea from the chemotherapy. And while he was on chemo, a new study of a PARP inhibitor was opened at the University of Pennsylvania for patients with BRCA-related pancreatic cancer. And this was not a maintenance study. This was the first PARP inhibitor study that we ran at the University of Pennsylvania for pancreatic cancer. And he was able to get on that treatment, which he started in October of 2014. And we'll get back to him towards the end of the talk. So briefly, just to talk about pancreatic cancer and kind of the basics. I call this a little primer. Do this for the fellows at the institution as well. So the pancreas is kind of a fluffy, elongated shaped organ. It lives right in the what we call the epigastrum, so just below the breastbone, right in the center of the belly. And it sits, as you can see here and appreciate, next to a number of important structures. So it sits right in the curve of the duodenum, which is the first part of the small intestine, right after the stomach. It sits near a large number of blood vessels, as you can appreciate. And it also sits right near a nerve called the celiac nerve, which sometimes explains some of the symptoms people develop with pancreatic cancer. The pancreas itself, in terms of what it does for us, it has two main functions. One of its functions is to secrete digestive enzymes. And if you look at this little track in green with a little arrow into the intestine there, it says digestive enzymes. And those enzymes help us break down fat. So those enzymes mix with fat and they break the fat down into its building blocks, which then can be absorbed by our intestinal tract. The second major function of the pancreas is to secrete insulin. And so it helps, as you might imagine, it's the major controller of our blood glucose. So those are the two major functions of this organ. So when people develop pancreatic cancer, unfortunately, a low percentage are operable at diagnosis, and that's in part due to the fact that it's kind of a sneaky disease and presents with symptoms that might mimic other things or no symptoms at all. For those with locally advanced disease, so we call people either operable, locally advanced, or borderline resectable, or metastatic. This middle category, locally advanced or borderline, means that the tumor hasn't spread anywhere, but that it's wrapped in blood vessels so that a surgeon cannot safely operate. For those patients, we often attempt to shrink the tumor down with chemotherapy and with radiation in order to get it to the resectable or operable state. And for those with metastatic metastatic disease, the treatment is often ongoing therapy, typically with chemotherapy, and as we'll talk about in this talk today, sometimes with targeted agents in certain situations. So this is the where we stand currently with pancreatic cancer therapy. And what you'll see here is that really remarkably, up until 2001, there was no active therapy for this disease, and the survival was extremely and horrifyingly short. In 2001, the very first treatment, single agent gemcitabine 1 drug, was developed and showed benefit in pancreas cancer. And then it took another decade before we had more treatments. But after that, you can see that the timeline gets thankfully a little bit shorter, 2011, 2013, 16, 17, 19, and 20. So we now have multiple options for chemotherapy for patients, for all comers. I have those at the bottom. So this is anybody can benefit from those first 4 therapies that you see there through 2016. And what you'll notice is that in the last 3 therapies that have been developed for pancreatic cancer, they are all targeted therapies for people with specific alterations, which is what a lot of what we'll be talking about today. Pembrolizumab, which is an immunotherapy, is for patients who have what's called MSI or MMR deficient tumors, which can be associated with Lynch syndrome. But olaparib, which we'll spend a long time talking about, and cisplatin and gemcitabine are very specific to patients with BRCA or PALB2 alterations. So as we move forward with this disease, we are kind of starting at the tip of the iceberg here to start to get some targeted therapies for patients. So in terms of testing, this has really changed since the last time I gave this talk, which was a number of years ago. So the current recommendations are that every patient with pancreatic cancer should be offered genetic testing. Doesn't matter the stage, doesn't matter how old the person is, doesn't matter if they have family history or not, every person should be tested. If you are the first degree relative of a patient who never underwent testing, then we offer that first degree relative testing. So let's say I had a mother who died of pancreatic cancer before she was ever tested because it wasn't the standard of care at the time, then I would be offered testing in that scenario. There are multiple platforms out there now, and they're sprouting all over the place that provide adequate testing. What you don't want to do is limit to BRCA variants only. And if somebody presents to our clinic who had breast cancer, say, for example, 15 years ago and was tested only for BRCA and was negative, we would then retest that person, but with a much broader panel of options, right? Because there are more than just the BRCA genes that can cause pancreatic cancer or lead to that can lead to an increased risk for pancreatic cancer. Oops, sorry about that. There are several panels, I've listed them there, and there are also ongoing efforts to reach patients who do not maybe have close access to pancreatic cancer testing, genetic testing. So the eReach study, for example, is aiming to try to offer people or get people tested who might not have physical access to genetic counseling. Positive tests may have implications across patients of every stage. It has implications for which chemo we might select for a particular patient. For the advanced disease setting, it may have PARP inhibitor implications. And now there's also a clinical trial looking at a PARP inhibitor in the adjuvant setting after curative intent therapy. So that means that that's not a standard of care yet, but there's a clinical trial for patients who have BRCA or PALB2, had chemotherapy and surgery and would ordinarily be watched. And there's a clinical trial in that setting, which just brings home the fact that testing should be offered at any stage because it might have implications for the treatment of the patient. Of course, what I don't have listed there is that it has implications for the family members as well, which we may touch on a little bit later in the talk and certainly in this conference. So based on various studies, about 5 to 15% of patients with pancreatic cancer have an inherited mutation with BRCA1 or 2 or one of the other genes that can lead to an increased risk for pancreatic cancer. Some important things to know about that. Screening for pancreatic cancer is now recommended for patients with a gene, so BRCA1 or 2 or PALB2 or another, and a family history of pancreatic cancer. responses to chemotherapies for patients who have a specific genetic alteration and are diagnosed with the disease may be different than what we would offer in the general population. And PARP inhibitors, as we'll talk about, represent the first targeted therapy in that group. This just shows you the lifetime risk. So the lifetime risk for pancreas cancer is a little bit different between BRCA1 and BRCA2, with BRCA2 carriers having a higher risk in general than BRCA1 carriers. So as I just said, there are other clinically meaningful variants beyond just BRCA, that other genes that basically alter the DNA damage repair pathway, and those can be altered as also in pancreatic cancer beyond just BRCA1 and BRCA2. And this is an evolving group of mutations, because as we learn more, we add to this list. And as we learn more about who those patients are and what drugs they might respond to and what trials we should have for them, that list is kind of a shifting sands at the moment. So for example, I've listed some of the variants here that might increase the risk for pancreas cancer. But as you can see, a lot of the questions are they actionable? And that means in the drug setting. So if the person has pancreatic cancer and has, say, an NBN mutation, what drug should we be treating that person with, and can we target them, for example? So those are things that are being developed, being researched, and being studied, but there is not yet an FDA-approved target for patients with that gene, for example. In addition, there's some genes that might increase the risk for pancreatic cancer, but might actually not be druggable in the way that we thought they were. So CHEK2 and ATM are two examples of those. We're still really trying to work out which drugs we can use for those patients that will be the most effective, even though those genes do increase the risk for the development of pancreatic cancer. So a lot of that is in the research realm at the moment. Okay, so briefly, why does BRCA matter? How does it work? So here you have on the left a double-stranded double helix, a DNA double strand, and you can see that there's two and they're wrapped around each other. Platinum chemotherapy causes cross-linking between those two strands, and when the DNA tries to unwind, when a cell tries to divide, the DNA there cracks, basically. If you do not have a BRCA variant, your cells can actually fix those double-stranded breaks and the cell will survive. But if those cells are mutated in BRCA, the problem with BRCA mutations is that double-stranded breaks cannot be adequately repaired and the cancer cell dies. And that is why platinum chemotherapies, and we'll talk about those, but just to tell you now, they're cisplatin and oxaliplatin, both platinum-based chemotherapies, are highly effective in people with pancreas cancer and a BRCA variant. And we see that across BRCA-related cancers. So here we showed, this is a retrospective study where we showed that platinum chemotherapy retrospectively, which you need to take with a grain of salt, but that it looked like platinum chemotherapy helped people live longer if they had a BRCA variant than if they didn't. So here you see in a blue line over on the left upper panel in panel A, here you see on the y-axis, you see survival probability. So 1 is 100% and 0 is 0%. So everybody starts at 100. Everybody's alive at the beginning of the look, right? And here you have the BRCA group in dark blue, where you can see that at the end of as long as we looked at these patients, a fair number of them were still alive. The line never goes to 0. And here is the control group. Those are people without without BRCA variants. But why are they living so much longer? So there's probably two reasons. One is that BRCA variants might just be prognostic, which means that they might, those tumors might inherently be a bit friendlier. People may live a bit longer with those tumors than for someone without a tumor. But the second is they may be predictive, which we just talked about. They're predictive potentially for response to platinum chemotherapy. So here in panel B, which is on the right, you see in blue, we looked at all patients, BRCA variants and controls, everybody who got platinum, everybody who got FOLFIRINOX or gemcitabine and cisplatin. And you can see that that line, that curve separates even more than it did in panel A. And these people also received platinum, but these people did not have a BRCA variant. And then in C, we said, okay, well, now let's look at everybody without platinum. Everybody didn't nobody received platinum and in this group. And you can see that the curves are closer together. They're not exactly together, but they're closer together. And what that implies is that there's at least a predictive biology to BRCA. In other words, the patients with BRCA and pancreas cancer did much better when they got platinum compared to not. And that accounted for the majority of the benefit that we saw in terms of their survival. Now, this is retrospective, which means that it's not gospel. It's a look and it's hypothesis generating, which means we see this, we think this means they may do better with platinum. Now we have to prove it in a clinical trial, right? That's always the next step. So here was a clinical trial that looked at platinum chemotherapy in people with BRCA or PALB2 variants. PALB2 is very similar to BRCA and is actionable. So in this trial, what they were trying to actually look at was whether the addition of a drug called veliparib would help patients with pancreas cancer and BRCA or PALB2, but they actually showed something different. So they took patients with pancreatic cancer. This was published just last year. No prior treatment, and stage 4 disease, which means metastatic disease where the tumor has gone to other areas, and a variant. 25 patients in each arm. So 25 patients got one treatment and 25 patients got the other. And they looked at either cisplatin and gemcitabine, which is on the bottom, or cisplatin, then gemcitabine and veliparib. And their goal was actually to show that maybe veliparib might be helpful. But you'll see in a second that they showed actually something equally important and different. The primary endpoint was response rate, which means we're looking for how many patients are having a response to the treatment, how many people are having a real shrink. And here's what they showed. So this is what's called a waterfall plot, where the y-axis here shows you how much tumors are shrinking. So all the way on the bottom is minus 100%. That's called a complete response, means everything disappeared off the imaging. But you can see that there's 30%, 40%, 50%. There's lots of shrinkages before you hit 100, right? You can see that the red and the blue, those are the two different arms. So some of these people got chemo plus veliparib and some people got chemo alone. You can see that they're actually, you can appreciate that the colors are all mixed together, which means there isn't really much of a difference here. But almost everybody went down, is on the down curve, which means almost everybody had shrinkage in their tumor. And the response rate in both arms was extremely high. About 70% of people with BRCA or PALB2 had a response to platinum-based therapy. And just for reference, in the general population, our best chemotherapy has about a 30% response rate. So this was a really important study, not because of the addition of veliparib, but because we showed, or the investigators showed, that people with pancreas cancer respond prospectively in a trial so well to platinum-based therapy, and that should be our standard of care for these patients. In another retrospective study, we looked at other regimens. What about FOLFIRINOX? What about FOLFOX? And again, retrospective, so not to be taken as gospel truth, but we showed that the response rates retrospectively for patients with BRCA were also looked very high. They also looked very high to FOLFIRINOX or FOLFOX. And interestingly, even though this was retrospective, the response rate that was observed here with cisplatin and gemcitabine, the one I just showed you, was about the same in the retrospective study as it was in the trial. Of course, just nice to see that. It helps lend some legitimacy to the retrospective study. But the response rates to the other platinum drugs was actually almost as high. So it gives you some options in terms of treatment. So you can base it on the patient, but the bottom line is that platinum-based therapy should be the standard of care in the first line incurable setting for patients with BRCA and pancreas cancer. Here I just list the different kinds of platinum therapies that can be offered. So your doctor or a doctor may choose any of these and it would be considered reasonable. Okay, so now let's talk about a new problem. So as we showed in that case study in the beginning, that patient was on that chemo, which is tough stuff, for about 1.5 years before he sort of needed something else. And the problem with people with problematic, it's a great thing, but it also lends to a problem. So people with incurable pancreas cancer and BRCA often do exceptionally well with chemotherapy, with platinum-based chemotherapy. And that is fabulous in a disease that we have trouble controlling in general, but it means that there's progressive toxicity that we then have to deal with. So we need a better option for those patients. You can't keep a human on chemotherapy for years. It isn't tenable for most patients. So there's this new model that's now been developed. to, this is a proposed model, to use the chemotherapy as what we call an induction, meaning that you give the chemotherapy, you give the chemotherapy to stabilize the patient, to shrink the tumors down a bit. And then once you're there, maybe 4 to 6 months in, depending on who you talk to, then to consider maintenance options, meaning something less toxic that might continue to control the disease. Let's skip this because it did something funky here. Okay, so we talked about platinum and how it works before. And now we're going to talk about PARP inhibitors, which is this class of agents which now have an approval in BRCA-related pancreas cancer. So PARP inhibitors are slightly different than chemo, and some of this explains their lower toxicity compared to chemotherapy. So although platinum therapy causes double-stranded breaks in the DNA that cannot be repaired by a BRCA mutated cell, we also have lots of random events throughout the day that just happen in our cells, sometimes induced by something like radiation, even going out in the sun, for example, that cause single-stranded DNA breaks. So single-stranded DNA breaks are just when there's one little mutation at a spot in that double helix, okay? And the PARP enzyme, which you have, even if you have a BRCA variant, will fix that. We'll just take care of it, no problem. If you give a PARP inhibitor, that single-stranded break is no longer reparable because PARP is no longer active. And in addition, PARP inhibitors, the good ones, lock themselves on the DNA. It's called PARP trapping, locks the PARP on the DNA, and it causes a lot of collateral damage. And what ends up happening is that single break actually progresses on its own to a double-stranded break. And as we talked about before, the double-stranded breaks cannot be adequately repaired in a BRCA variant. So it's not directly, PARP inhibitors don't directly kill cells, but they prevent repair of small breaks leading to large breaks, which then ultimately the cell cannot repair if there's a BRCA mutation. So here is a beautiful phase 3 study that was published in the New England Journal of Medicine in 2019, trying to give people a chemotherapy break. So it was a phase 3 trial. This led to the FDA approval of olaparib in this exact setting. So these were patients with incurable disease, a BRCA variant or mutation, at least 4 months of chemotherapy without progression, meaning showing that their cells were sensitive to that. They were randomized now 2-to-1, 92 patients to 62. The 92 patients received the agent, olaparib, twice a day, and the 62 patients received a placebo. We can argue about the design of this, and there's a lot of controversy about that design, but bottom line, it was a very important study. So 2-to-1, PARP or placebo, and the endpoint, the primary endpoint was progression-free survival, which means how long did it take for the cancer to start growing again. Here is what they showed. They showed that when you gave the PARP inhibitor, the olaparib, you had a longer progression-free survival than when you got a placebo, which was important news. 7.5 months progression-free survival versus 3.8 for patients who got the placebo. And so that led to the FDA approval of the drug, and it was the primary endpoint of that trial. And this is now an option for patients who need a chemotherapy break after 4 to 6 months of chemo. That said, though, I've highlighted here, I put my own little drawings in here to show you how variable the results actually were. So there is a group of patients here. This is time on the bottom, and this is probability of being on the study still, so having a stable tumor. So everybody starts at 100% of people start on the trial, and people start to fall off the trial by about 2 to 4 months. So if you take a look, there's about a quarter of the patients who were on the study had less than 6 months on the trial, meaning their tumors did not do well and they started to grow. There was then a big group in the middle who were on the study for 1 to 2 years. Okay. And then there is this little tail here of about 23% of patients, or 20% or so, who were on the trial for well over 2 years without progression. And so what you're noticing here is a big spread. And what we need to figure out as researchers is who falls into which category and how to predict that more effectively so that you can better target the therapy to the right group of patients. So what you're seeing here is wide biological variability in these tumors, even within this group of BRCA carriers. So one of the things that we're working very hard on is to try to figure out who those people are. And for those that do not have that big advantage of at least a year, let's say, or people that are in that tiny group, what should we be doing for them? How do we make this therapy better? Okay, so here is another study that was done. This was done at the University of Pennsylvania. This was another PARP inhibitor chemo break study. And the reason that this was important, this was a single arm study, which means everybody got the drug, okay, which changes your statistical validity basically of a trial. Randomized is always more valid, really, because you're comparing groups together. But here you have patients with inoperable disease and BRCA or PALB2, and we allowed germline and somatic. And so what you're seeing there is that we're adding to the group of patients who might benefit from this treatment. Gave everybody rucaparib, and as you can see here, the survival was about 2 years, but the progression-free survival was a bit over a year. And just like that cis-gem curve, you can see that almost everybody is in the downward slope across those variants, which is helpful because it adds a group of patients for whom PARP inhibitors may be effective, right? We're adding PALB2 and we're adding people with somatic, meaning non-inherited mutations in BRCA1 and 2. And this is the map that we showed of all the patients who came to Penn for that trial, which just shows you that people really want a chemotherapy break. They were willing to travel to get to us to get that break. And it was helpful for me to understand how hard that long-term chemotherapy must be, that they felt like they wanted to do that. I'm going to talk very briefly about future directions here. For incurable patients, there's a lot of interest in immunotherapy as it relates to PARP inhibitors and how it relates to BRCA. And so that is actively being worked on. And this is really a reference for everybody to just have and to look at. These are kind of a snapshot of a whole bunch of trials that are doing PARP or PARP plus immunotherapy or PARP plus other drugs, just showing that there is a lot of activity to try to improve on PARP inhibition alone. And I have the trial numbers listed there on the right in case any of those might be of interest for anybody listening. Okay. New science for curable patients. We've talked about platinum therapy is probably the best one to give. The standard for the general population now contains platinum therapy, FOLFIRINOX, which is great. And so people who are getting surgery should be having platinum with BRCA, should be having platinum-based therapy if that's at all possible for them. And this is a trial that is ongoing. That is going to hopefully help improve the cure rate, we hope, for patients with BRCA or PALB2 and pancreas cancer. And this is very similar design to the Olympia trial for breast cancer, which was just a big announcement this year in June, that PARP inhibitors help people in the adjuvant setting with BRCA-related breast cancer, meaning their surgery, they're done with their chemo, they're done with their radiation, and they had high-risk disease. PARP inhibitor for a year was helpful. We're doing the same thing here. Curable pancreas cancer, got all your standard treatment, would ordinarily be observed. And in this setting, we are giving a PARP inhibitor or a placebo for a year. Again, a 2-to-1 randomization there. Very briefly to talk about prevention. I know this is a topic that will be talked a lot about during this conference in general, but if it's generally recommended that persons with high risk for the development of pancreas cancer get screening. And that includes people with a high-risk gene, and a pancreas cancer in their family, or somebody with multiple relatives on the same side of the family with pancreatic cancer. We are still working out how to screen people the best. Is it endoscopic ultrasound? Is it MRI? Is it a combination of both? This is an ongoing study in that space, being run primarily by Michael Goggins at Hopkins and open at several centers. So it's called CAPS-5, and it involves ultrasounds to look for the development of the disease. These are the cohorts that are accepted. This is, again, just for reference, people who are able to potentially join that trial. And just to wrap up, what happened to our patient? So our patient who had all his he started rucaparib in 2014, and as of 2021, 7 years later, he is still on that drug. He is still well. He's still, with his metastatic pancreas cancer, still alive. And these are the people we need to figure out. Why does he have this response? How can we get other people to that level? And that is the end of the talk. This is my contact information. That's my office number. If anyone has questions about any of the trials I talked about, feel free to reach out. And I've also listed the email address of our nurse navigator at the University of Pennsylvania, should she be of help to you. Thank you so much.